So we saw the CT scan of the patient, and one of the concern
Yeah.
is that so if we use the Bavard methodology, the annulus matches the intercommissural distance. Everything is in favor of a 34 millimeter device.
Yeah.
But we had, I had the feeling
faire
that
des
maybe
rayons?
there are two commissures that are fused. In fact, it may be a type 2 bicuspid valve.
Yeah.
And so in a type 2, the 34 will be extremely difficult to position. So this is going to provide us with the answer. I guess you're going to predilate, or
Yeah.
so also the predilatation and the way the balloon behaves is going to give us information about the fact that it is a type 2 or a type 1. Type 1, you're going to get a very good result, I'm sure.
Yeah, I thought
might be difficult.
I thought initially, without your input, that it was a type 1. So that was, according to this methodology, it was kind of a tubular configuration. And then I made the choice of 34. But you're right, we will see. We'll see. So, few words. You have described and you have seen the anatomy.
Yes.
Few words about the overall condition and of this patient. So it's an octogenarian patient, quite small body surface area, former farmer, retired in the countryside nearby Toulouse. Past history of COPD, of paroxysmal atrial fibrillation, moderately impaired LV with 45% of ejection fraction, systolic pulmonary hypertension at 60, and moderate to severe chronic kidney disease with glomerular filtration rate at 35.
Okay.
So based on all of that, and without any obvious,
I think it's a good surgical candidate, no?
Yeah, without any obvious evidence of excessive frailty, so a good TAVI indication, right? Okay. The reason why, as opposed to our routine setting, je vais prendre la pictelle, on va la mettre pendant ce temps, Leila. And as opposed to what we have said, done, and what you have seen during those days, you saw that I was currently inserting temporary pacing leads through the right femoral vein. The reason for that is that this patient has at the baseline ECG. He has, as maybe you can guess on the scope, he has a PR interval that is at the upper limit of a normal. He has a complete right bundle branch block plus a left hemi block. So we know that those patients that are at really high risk of high degree and third degree heavy block during the procedure or after. We discussed that just before DJ joined us after his case. So that's why for that particular and typical setting, I prefer to implant a temporary pacing lead in advance. And we have different models here of temporary pacing leads. We have some were 6 French, quite easy to position, but a little bit rigid. And when I anticipate to leave the patient for at least 24 hours with a pacing lead inserted, I prefer to use this softer model. That is a 4 French one, balloon tip.
So these patients can't ambulate, so they can't.
No, he won't ambulate until tomorrow.
Yes.
But we'll decide whether to implant a pacemaker or not before tomorrow morning. So we'll make the decision today after the case. I would be surprised if we don't have any third degree heavy block during the procedure. And if it's the case, we'll schedule the pacemaker implantation for tomorrow morning. Okay?
Yes.
So while preparing everything, I've already done the local anesthesia, the echo-guided puncture. Do you want to shift and you put the ProGlides and do the rest of the procedure? It's fine for you?
Yes, if you guide me through.
Yeah, of course,
yeah.
I will do.
Sure.
I will handle the X-rays, so you can press a little bit here. I'm going to dissect for you the subcutaneous tissue. Ok, and donne-moi, Leila, le starter, s'il te plaît. 0.35. And we can do that with a short wire, but it's an opportunity to make mistakes because you can lose it. So what I'm going to do is to put the long wire in. This way it will be easier and we'll avoid any mistakes, we won't have any risk of losing the wire. Okay, so I'm going to give you a first ProGlide. So we made the choice, Didier, as shown during this case, to use the mount I use. I chose to use the ProGlides in order for you to have a mixed overview. Okay, you're familiar with the ProGlides or not?
Yes.
Yeah. So you know that, huh? Okay, so you enter that like this, 45 to 60 degree angle. Now I can withdraw the wire, enter until you have a backflow.
No back. This. Okay.
Yeah, it's fine. Turn
45.
counterclockwise to 10. Okay, open the foots. I help you.
Okay.
Okay, pull on the device until you're stuck. No backflow. You can connect by pushing here. Yeah. Okay. Pull on the string. Get it. Perfect. I help you.
Thank you.
Yeah, you can pull. Thanks. Close the foots. Okay. I will help you. You can hold the two sutures. Pull on both of them together to remove the slack. That's fine. And secure it to a drape.
Yeah, it's really an additional safety maneuver to remove the slack, because we've seen that the efficiency of the ProGlides has been improved by doing so. It will avoid to drag the nut within the vessel and to disrupt it. So it's better to remove the slack
I think so.
at the start.
Compress.
Yeah, second one. Vous avez préparé la valve, les filles? C'est en cours.
So which size of balloon are you going to use, Nicolas?
Sorry, Didier, because I had another question at the same time. Sorry, what was your question?
If you will use a cerebral protection device in this patient.
No, I didn't, but we could have chosen to do that. You're right, because we're going to pre-dilate, maybe have to reposition, post-dilate. So you're right. Didier, what was your question?
It was just bouncing on the pre-dilatation issue.
The balloon size.
Yeah, balloon size. We have to discuss
so
that.
if I remember, the intercommissural distance is between 26, 27, right?
It was even 29.
29,
what you measured, and the
Okay.
minor axis of the annulus was 26.
Yeah.
26,
So
and
I've chosen for the initial pre-dilatation a kind of
smaller balloon.
Smaller balloon. It's a 23.
And it could be interesting to if you inject contrast at the same time.
We'll do that.
It seals or not.
We'll do that, and I have prepared in the room, just in case we need for post-dilatation, both 25 and 28.
Okay.
So this is already prepared, and if we need it, we'll have it. Okay, so this is the Lunderquist wire.
Oh,
you
so
can
straight with the Lunderquist, okay.
But you can reinsert directly. Okay, and I will hold the X-rays for you. It will be more comfortable. So I do it for you.
Okay.
Yeah. Okay, and you see sometimes you can use the ProGlide as a sheath in order to drive insertion of the wire. You see?
Now it goes fine.
Now it goes fine, and then you're able now to withdraw the ProGlide. Okay, and I'm going to give you the sheath. So heparin has been already given to the patients. It's 3,000 units, and we'll take a blood sample to monitor the ACT. But I think given it's the dilator has disconnected. Yeah. Given is chronic kidney disease, I think it should be enough. Okay, that's fine. So you can hold the sheath and I will remove the dilator for you.
Thank you.
I will also take a blood sample for the ACT. Je vais prendre la seringue, Leila. Elle est là. Okay. We flush, as Didier mentioned already, a lot. Okay, good. Dry and clean the wire. And this is for you.
This is the AL1?
Yeah, this is the AL1.
And if you want a projection, we have something like LAO10 0 craniocaudal.
Okay. LAO10 and face. Okay, I think the pigtail is not pushed enough. I will push it a little bit more. Yeah, if you can.
Yeah, and sometimes with bicuspid you have so many
Yeah,
calcium
you have
that
some,
you can really you can't really be deep as you wish. So it's implant
So
left
should
one
we do an
and
NGL first?
No, you can. Yeah, it's implant left one, regular stiff wire, regular straight wire. Sorry. We'll have as a bailout in case we have some troubles to cross the straight Ferrimo. But we're going to try a few seconds. I can, I think it's the right, yeah, it's the right, yeah. I can remove a little bit, yeah. Sometimes also in large anatomies and especially in large bicuspid anatomies, the curve of the L1 is not enough.
Yeah.
And you're not enough coaxial, so it can create some difficulties also to find the good spot to cross. So one solution can be to change to an AL2 after a few seconds if you need, if you prefer. But you will tell me what you prefer. We can either change the wire or the curve of the catheter, whatever you want.
We usually change the catheter.
The catheter AL2?
Yes, please.
Yeah, AL2 s'il vous plaît. Un cathéter AL2.
Keep on.
And maybe you can map a little bit more faster. Sorry. It could help you to cross also.
Yeah, sure.
It's slightly. I'm going to give you one question is about the diameter of the ascending aorta. I'm going to give you the dimension of the sinuses, but it's a very large.
It was large, but not aneurysm. I made the measurements.
Yeah, it's 37. The sinuses, the mean diameter, and the STJ, for example, is 33. Ascending aorta is 35, so it's not a dilated configuration.
Et tu peux purger la pigtail une fois. So it's a short wire, but don't worry, you can advance the catheter, and I will have a tip here. You can advance.
Sure?
Yeah. You can advance again. Yeah, that's fine.
You still have the pedal. Okay.
Okay. So maybe with this one, it will be
it's a
more
L2,
coaxial.
yeah.
L2, yeah. L2. Et Laetitia, elle est là? Allez chercher sans l'ouvrir pour l'instant un Terumo droit. And we prepare, without opening it at the moment, but we'll have it ready, a Terumo straight in case you still have some difficulties. And we know that crossing it's such anatomies, it's sometimes
it's
more
really,
difficult. You were there.
I was
you did it once.
You did it. So you will do it twice.
You did it twice, 3 times.
So
yeah,
perfect.
don't show off too much. Huh?
So we're
Lucky
going
day.
to record the pressure. I'm going to do it for you. Flush. Vas-y, purge la pictelle en injectant. Okay, so as we mentioned, you see we have a depressed LV function.
LV,
Yeah, poor gradient.
Lot of arrhythmia.
But what is
excitable
important?
ventricle.
Yeah, what is important to notice apart from the gradient is the level of LV and diastolic pressure. So we're at 243. Yeah, 15, 20, and diastolic pressure, aortic diastolic is at 40. Okay,
Yeah,
so let's keep in mind.
Maybe you have already have a regurg at baseline.
Yeah, it was described by the TT.
Okay.
We had a 2+ a regurg associated with this stenosis.
No, because it's LV function is depressed. So,
Okay.
you see the amount of regurgitation. It's really...
So I go in RAO.
Should I go further in with the catheter?
sorry.
Is
No,
it
I think
alright?
I think it's
severe.
fine. You will be able to.
Yes, when you see
The
the
LV is
calcium
quite.
load.
Then you can push on the catheter, yeah, and extrude the Safari. Okay, and as you did, as Didier showed during exactly perfect. During the last case, reinsert and re-extrude. Perfect. Okay. I will finish it for you.
It's a very large left ventricle, and we can see.
Yeah. I'll let you. No, we're going to pre-dilate, and then we'll change our gloves and do the valve implantation. So what we're going to do? Yeah, I think we're fine here. Et Leïla, on injectera pendant la valvule.
So what size of balloon have you
It's
chosen?
23. It's 23. A little bit undersized as compared to the intercommissural measurements,
C'est bon.
and as compared to the minimal diameter of the annulus. C'est bon. You can advance. I have a wire. Et vous serez prêt à stimuler à 180? Okay, that's fine. I think you can hold it right. Tu gonfleras, Leïla? Ok. Vous êtes prête, Laetitia? Pacing on. Okay, pressure drop. Okay, balloon up. Okay, stop. Okay, we just have a small confusion. Stop pacing. With the stopcock that was closed, and that it was impossible for Leïla to inflate, so it's closed and closed, and you push everything. Okay. Okay, so pacing on.
Should we withdraw it a bit, or is it?
No, I think it's
not
fine.
too deep.
No, I think it's fine.
Okay.
I'm holding it. Okay, let's record that. So balloon up, inject. Okay, everybody is sleeping here. Okay, stop pacing. We will take time to review everything. So you see that we had the balloon burst, huh? It exploded. Okay, so let's review.
It's severely calcified. Because
Okay,
this
let's review
balloon
that.
is quite stiff. It's a stiff balloon.
Okay.
If you have a rupture, it's mainly because of the calcium.
Yeah. So first assessment regarding the relative sizes.
Yes.
It's still a little bit small, so that's fine. But without any residual resistant raphe, I think. So it's fine. So
and the coronaries are still,
and the coronaries,
perfused.
coronaries were not an issue. So we can change our gloves, and we're going to proceed with a valve implantation. Thank you.
Any perforation of the sapien? Sometimes, yeah. It happened once, but the balloon ruptured, so you need to bring another balloon, more compliant balloon, more non-compliant balloon, like an Atlas. Yeah. It's sometimes.
What is interesting to notice
It's a steel balloon,
also
but you can-
is that we don't have at the moment yet a third degree heavy block. So the BAV was not the driver of a third degree heavy block.
Oh.
So we'll see while we will implant the valve if it occurs or not. Okay, I let you just press a little bit. Thank you. And we're going to take the valve. Here you are, and then you don't have to press anymore. Just enter. I'm going to show you what you're doing. You want a wider view to the...
Yes, please.
I'm going
Thank
just
you.
wait a second.
Yeah, here we are. It's not much, no resistance really.
That's fine, huh? Okay,
Okay, we
let
are
me just
in.
go above. That's fine. So I will adapt to your movements and pull on the wire to help you navigate through the arch.
Yes.
Okay, and I'm going to zoom in a little bit for you and think we can already advance a little bit more deep with the pigtail, but yeah.
There.
Yeah, it's there.
that was
I think it's fine.
And here we are.
Okay, and maybe
Close the
we.
ring.
So it was the incident that was given by the city, but as sometimes we have to do, I think we have to fine tune it a little bit in order to align on the capture. I think that position is not so bad, and now we're going to record. We haven't done a lot of angio before because you remember the chronic kinesis of this patient,
Yes,
so
yes.
we're going to try to avoid it as much as possible. Okay, so regarding our target in the non-coronary sinus, I think we're fine. Huh? What do you think?
I do agree.
Okay,
Yes.
so let's start
start.
like this. I will adapt to your demand regarding the speed of unsheathing. We'll see if we have to pace in case we start to be unstable.
Yes.
Vous serez prête si besoin à stimuler à la molette à 150 si besoin?
The depth is still all right.
Yeah, I think so.
Okay.
We'll make a test a little bit after. Maybe you can pull 1 millimeter more if you can, slightly. Un petit test, s'il vous plaît. Okay, that's fine. And you see, interesting. We can make a pause here. You see that we are starting to have some heavy block. Huh? You see, huh?
I noticed.
Yeah.
Yes.
Yeah, we see that.
We see that we start also to have a kind of little instability. So maybe we can start to pace, and it will, in this large anatomy, it will help us to have a more accurate positioning. Okay. So that's perfectly stable. Okay, I'm going now.
A little faster.
Yeah, you can push. Ok, et vous pouvez diminuer à 100, 80
Ah oui,
et 70.
Yes.
Yeah, the depth is
Ok,
nice.
let's record that. Et 60 de fréquence.
It was quite stable, so it's more in favor of a type 1 bicuspid.
Yeah, I think so.
Because type 2, you would have been pushed downwards.
Yeah, we're going to record our position. Yeah,
It's good. You have a tiny regurgitation, but
Yeah.
it's very small.
very small regurgitation. We are only at 1 millimeter in the non-coronary side, 2-3 in the left.
In the left, yeah.
But we anticipate
You see
maybe
what-
not to have any need for post-dilatation,
Yeah.
hopefully.
And so that's what I was explaining to our colleagues, is that in bicuspid, angiographically, you will still have the feeling that you are high when you look at in the non, but most of the time in the opposite side, you are really 3-4 millimeters below the annulus,
Yeah.
and that's what we see.
So I think we're fine here.
Yes.
Yeah.
So as
And
we're
it's good for this patient to have a high position because of the risk of AV block.
heavy block. So as we are in this high position, we're going to keep the pigtail here just to have a more precise landmark for final release and to be sure that we won't move.
Should I have a push on it? To
So
release?
you saw that while discussing, what I've done is just to pull on the stiff wire. You can also test a little bit the stability by pushing now a little bit, and you see that it's fine. It doesn't move.
No.
So I think we can release it. Okay. So you can
A slight push on
Yeah.
the valve.
slightly pushing. You can keep on pushing. Yeah. Push a bit more again. And the valve is free, I think. That's
No,
fine.
it's free.
Again, the same tip. You can release the catheter. Release it. And you see that just pushing, pulling on the wire, we disconnect it. So it's fine. And I'm going to do that by my own. You can just... Thanks. And we're going to reinsert the sheath. So we were at, while waiting to insert the sheath, we were at 40 of diastolic aortic pressure. We're almost at 60 now, so I hope it's the reflect of the good outcome we'll have. Okay.
Yeah, it's
I'll
really
do it
there
for
is a
you.
real improvement in the diastolic pressure.
Yeah. The patient, est-ce que vous pouvez vous mettre à 30 de fréquence, s'il vous plaît? Let's see if et la pictelle dessus. Ouais. Because we sometimes have
Vérifier qu'il ait demandé les scanners post
some pacing.
hier et aujourd'hui.
Okay.
Pigtail?
Yeah, it's a pictelle for hemodynamic recording.
Faut le dire.
Okay, so
Oh,
it's...
well, it's
Demain,
you were out? No,
c'est le jour,
if,
c'est le jour.
don't worry,
Oh,
we're
it's
going
not,
to... Yeah.
It's okay.
I'm going to give you a wire. Oh, that's fine. Perfect.
a bit too fast for me.
And this is here. And we have a spontaneous rhythm of a patient. You see?
He's going to deflate the balloon to leave it there. So one comment is when you will end the procedure, will you keep the tip of the balloon inflated or will you deflate it?
Of
the pacing lead.
Of the pacing lead, yeah, we will deflate. Sorry. Yeah, sometimes it happens. So it's the stopcock of the 18 French sheath that was left open. And if it's below the drape, you don't notice that immediately, and you notice that when you have blood on your shoes. It's not your fault, huh? No worries. So let's assess the hemodynamic. It looks good, huh? The LV and diastolic pressure is fine.
It's already really nice.
Yeah, diastolic pressure is 60 as it was 40, so I think it's fine.
And
so we can remove that.
And with bicuspid, so would you go to RAO?
Yeah, I will do that. I'm just removing the gelled pigtail with a wire. No. I have a question about whether it's possible to disconnect the pacemaker. So my answer was no, because although we don't have at the moment the degree of block, we know that this patient is at high risk of delayed. So he will go to the ICU with a pacemaker. On va reconnecter l'injecteur, s'il vous plaît, Laetitia. You have it like that. And let's go to RAO to assess the... So I'm just, without n'injectez pas, hein? Just record that in our working projection. And now in RAO, going to record that also. No, je vous dirai. Oh, it's fine, huh?
It's nicely expanded.
Yeah, it's nicely expanded. So let's come back to our projection. It was close to that, and let's record.
Is it okay there?
Yeah, it's okay. I think so. let's record the angio. It's fine.
It's very nice.
Yeah, we have this final depth of implantation is quite good, huh? Not too high, not too low. Very small, tiny regurg without hemodynamic, without hemodynamic impact or nothing.
Open coronaries.
Yeah, so I think we can be happy with these results.
Yeah.
Would you post-dilate, Didier, or in the room you would post-dilate here?
No, personally, I always tend to post-dilate because it's my policy for back.
Yeah, you're a post-dilator, yeah.
Yeah. Here it's true that the immediate result is very good.
Yeah, okay. So that's fine. So we're going to close. I'm deflating the pacemaker. And I'm going just to do that for you.
One day. Tomorrow there is still something. It's already reassuring that the conduction disturbance disappeared, even with the valve in place. So should be fine.
Okay, and the second one is here. Thank you. And the nut pusher are here. Okay, thank you. So shall I ask you to just pull on the sheath with the wire in place, please? And just, yes.
Okay.
Yes, please.
Pull slowly.
Yeah.
Out.
Thank you. So this is the first. Let's do the second. Okay.
Nice.
Let's assess that. Oh, that's fine, I think. It's quite a thin patient, so in case we have a small residual bleeding, it will be easily compressed. So I think we can remove a wire and tighten another time the knots. Okay. And let's come back. I'm going to press that, and we're going to come down in order to record the last angio. Sorry, I'm going to take the X-rays. Tu peux te remettre en champ 0, s'il te plaît? Et ouvre la collimation. Merci. So yeah, it can be sometimes difficult, but
across the...
Okay. Just need enough support and enough length. So that's it. Sometimes when you don't have it in such tortuosity, when you don't have enough support, we use a stiff Terumo wire.
Okay.
That makes things a little bit easier. Okay.
There you are.
And we are just...
Yeah.
We'll have 1 or 2 centimeters that are missing because of the tortuosity. So I will stay there. It's not an issue.
C'est rare que tu sois trop court, mais...
Ouais, j'osais pas. Et on va se reconnecter à l'injecteur, s'il vous plaît. en soustraction.
Yeah, so you will do a conventional arthrography of the
Et
abdominal
30
aorta and
30
both-
cc.
both vessels, yeah. Good.
Ok.
Yeah, really nice.
Good.
Oh, it's fine. Okay.
Parfait.
So I think, and what we will do is just to keep the pacing league at least until tomorrow.
Yes.
And as referring to the publication I showed to you about from Offray, to my opinion, it's really difficult decision for such patients. I would advocate for a pacemaker implantation based on the survival data you've seen. The only issue here is that he had a depressed LV function, so it's not nothing also to implant a dual chamber pacemaker in somebody who has an impaired LV function. So you can imagine to implant a CRT device, but it's not the same morbidity and the same procedure. So maybe that will be an argument also for that patient to wait a little bit more if we won't have any delayed third-degree AV block.
Yes.
Okay?
Okay.
Congratulations, thank
Thank
you.
you.
My pleasure.
Very
And
nice.
yeah, we'll join you in a few seconds.